Hello, my name is Kimberly Walters, and this evening I will be presenting my Ape evaluation on the effectiveness of strategies for crisis intervention and prevention revised, SCIPR, on behavioral support for adults with intellectual disabilities. So first, I would like to start off explaining the purpose of my report. As someone who has previously worked in the day program for adults with developmental disabilities and has had some experience with SCIP training as a direct support professional, I was looking to evaluate the strengths and weaknesses of this program to determine the best ways to improve it. This study was conducted at 5 different residences in the Van der Heyden program. All are in the capital region of New York over a 6-week period. During this internship, my role was to shadow the direct support professionals and management. I used behavior data, life plans, skip trainings, discussions with direct support professionals, management, and residents, along with my observations to come to conclusions on how effective this practice is in the individualized residential alternative, also known as an IRA. So the community I'm referring to in this study are the residents in the Van der Heyden IRAs. They represent a larger population of adults with developmental disabilities in the state of New York. SCIPR training is used in other similar programs with different organizations. It is a requirement to utilize SCIP to receive funding from the Office for People with Developmental Disabilities, better known as the OPWDD. In these particular IRAs, the residents mostly have disabilities that impair their cognitive abilities and social skills. Very few of them have had physical disabilities that impair their motor skills. Some concerns that are unique to this community are homelessness and high adverse childhood experience scores. A successful program will help support the behavior challenges that come with the instability of homelessness and childhood trauma on adults who have trouble regulating their emotions and reactions. This study has relevance outside of Van der Heyden. Every adult program funded by the OPWDD in New York State can benefit from the results of this study because they all utilize SCIP-R. My vision for residential adult programs in regards to behavior support is every home having a DSP that can comprehend and display great de-escalation and preventative strategies relevant to the individuals they serve. My mission is to modify SCIP-R training so it will reflect specific individual needs rather than generalized techniques. So this SWOT analysis goes over some of the strengths, weaknesses, opportunities, and threats to success on behavior support in the 5 IRAs I observed. All of the managers have stated that they require their new staff to read through behavior plans and life plans. I have read through these plans and they are very long and very detailed. If the new employees are truly reading and comprehending these plans, it is a great strength for Van der Heyden programs because they will get a better understanding of each individual in the residence. One weakness is the lack of consistency in staff support, and another is high staff turnover. In this internship, I worked with older staff who have been in this field for about 10 to 20 years, and some younger staff who have been in this field for approximately 1 to 3 years. There's a drastic difference in their approach and interactions with individuals. Some individuals would be more prone to certain behaviors depending on who's working a shift. They thrive on consistency, so this can be a threat to behavioral support. The opportunity to improve on the SCIP program is the adult OPWDD programs. The high staff turnover rate is an issue because it is a threat to the consistency, and employees are leaving as soon as they become familiar with the role and can be an asset to the team. The first work product I accomplished is to attend a meeting on behavioral intervention strategies. On August 7th, I attended a treatment team meeting for the second residence I observed. To maintain anonymity of the residents and their address, I will refer to this house as IRA number 2. In this treatment team meeting, I discussed recent events and plans regarding health and wellness of each resident. I was able to discuss concerns I had regarding police intervention in behavior crisis and training staff to prepare for their role as a DSP. I suggested an update in the SCIP-R training that centers specific individuals in each residence and places more focus on prevention and de-escalation training. The second work product I completed was to evaluate the effectiveness of SCIP-R on people with intellectual and developmental disabilities in residential facilities. This was completed by analyzing behavior data, life plans, SCIP-R training, discussions with direct support professionals or DSPs, management, and residents. I used my observations of intervention and prevention to conclude on the successes and shortcomings of behavioral support taught in SCIP-R training. I shared my suggestions to improve SCIP-R training in meetings, and one of my suggestions was role-playing previous crises to find a better method to support the residents. I advocated for enhancing de-escalation techniques. This was inspired by Daniel's Law, a policy intended to decrease police intervention in behavioral crises and replace it with mobile crisis services. In the first week of my APE, I got to experience SCIP-R training that employees are required to attend for 2 days. The training starts off with an OPWDD approved PowerPoint on the history of the institution supporting the IDD community in New York. There were horrible histories of neglect and abuse in these institutions, such as Willowbrook. We have more protections for this community because of programs like SCIP-R. Um, I got a physical intervention training, physical intervention test, and more traditional written and multiple choice tests based on a PowerPoint lecture. I visited 5 IRAs and got to discuss preventative and de-escalation techniques. As previously mentioned, I was involved in a treatment team meeting, and I also got to talk to some residents in IRA number 1 about their experience in the program and how it was for them to move in. Finally, I met with Sarah Dallas, who was my APE advisor and Vanderheiden program director. I met with her 3 times to go over some questions and suggestions regarding behavioral support. We discussed rights restrictions, resident placement, and improving SCIP-R with specialized training for DSPs. There are 5 CEPH competencies my study connects to. The first CEPH competency, number 2, was selective quantitative and qualitative data collection methods appropriate for a given public health context. The work product is my evaluation of SCIP-R. The quantitative data used in this evaluation report is how intervention affects the number of times a behavior occurs. As an intern, some of the data was restricted, but I was able to collect this data through behavior support plans and life plans. They gave me some access to the number of times negative behaviors occurred and how many times coping skills were used. Qualitative data for this APE is the Vanderheiden survey some residents completed about their satisfaction with the support they get in their home. This qualitative data is also collected from my observation and conversations from SCIP-R class. The qualitative data revealed all recertifying staff did not remember how to do most of the physical intervention techniques to OPWDD standard. The next competency is CEPH competency number 4, which is interpret results of data analysis for public health research, policy, or practice. The product for this competency is also my evaluation on SCIP. There were a few instances of police intervention in all of the IRAs I visited. Police involvement in some IRAs creates room for more research on alternatives to improve de-escalation methods and find alternatives to crisis intervention. NY START is a mobile crisis service that has been used in some IRAs. I believe services like this should be utilized more. Daniel's Law is a policy to replace police in nonviolent mental health crisis management. This law was created after the killing of Daniel Prude by a police officer in 2020. CEPH number 11, which is select methods to evaluate public health programs, were also demonstrated in the work product SCIP-R evaluation. This evaluation was determined based on satisfaction of residents, satisfaction of employees, staff compliance with SCIP-R, staff compliance with behavioral plans, behavioral data, adherence to daily routines, successful crisis interventions, use of coping skills, change in behaviors over time, which were used to evaluate the program. Next is CEPH Competency 14, which is advocate for political, social, and economic policies and programs that will improve health in diverse populations. And finally, the last CEPH competency is number 19, which is communicate audience appropriate public health content, both in writing and through oral presentation. They were displayed in my work product, which is to attend a meeting on behavioral intervention strategies. In my meetings, I discussed advantages and disadvantages of SCIP based on collected data. I suggested methods to improve SCIP training by including role-playing exercises with DSPs. We discussed efforts to utilize behavior plans to improve de-escalation techniques, decrease police intervention, and replace them with mobile crisis services when possible. The evaluation report includes research to support suggestions along with public health promotional images advertising SCIP-R updates. As previously stated, SCIP-R is a methodology used in OPWDD-funded programs to support individuals with behavioral challenges. There are preventative, de-escalating, and physical intervention techniques DSPs are required to be trained and tested on. SCIP-R certified staff should be able to provide proactive and reactive support for crises. Some examples of proactive methods taught in SCIP-R are environmental modifications and learning triggers to avoid, such as physical touch. Reactive method examples are reducing demands, validating feelings, and encouraging an individual to go to a quiet place to decompress. So on the first day of training, we discussed pros and cons to SCIP. We agreed that some of the pros are providing behavioral support to those who have a hard time managing it on their own. The cons are preventative techniques are not always effective, and some physical interventions will not be possible to execute depending on the size of the staff and residents. Learning from the mistreatment of the IDD community, today we have laws, programs, and committees dedicated to protecting and enhancing the lives of this vulnerable population. Previously, the goal was to control behaviors. Now, SCIP-R program is designed to center behavior support and be proactive rather than reactive. According to the training, there are 5 functions of behavior summarized in the acronym MEATS: medical, escape, attention, tangible, and sensory. Employees are instructed to think of a possible medical reason for a behavior before anything else. For example, some of the medications the residents take cause constipation, which could lead to behaviors. Escape relates to avoiding an unwanted task or person. Attention is when they are creating behaviors to seek attention from someone else, whether it's negative or positive. Tangible is when an individual wants access to a desired item or activity. And finally, sensory is when behaviors are done to self-stimulate or self-soothe. The end of the first day of SCIP training involves self-defense training. We practiced deflecting objects being thrown at us, and we later moved on to more invasive techniques, such as the 3-person supine. The employees in this class have been with the organization between 1 to 10 years. Every employee or intern, myself included, who has been in SCIP-R certified classes in the past were unfamiliar with many of the steps for most of the physical interventions. SCIP-R restrictive interventions are designed in a way that's specific to restrain without causing harm to any individuals involved. For instance, the 3-person supine requires the 3rd person to hold the restrained individual's leg above the knee. The instructor had to remind employees multiple times to adjust their approach to avoid harming themselves and the hypothetical resident when we practiced this technique. Employees admitted to being unfamiliar with the physical interventions because they never or rarely used them. Based on the training, if employees were required to utilize this restraint in a few weeks, it is likely to be done incorrectly. However, according to personal narratives of the DSPs, preventative techniques and de-escalation tactics taught in this class have been effective. So, what is the purpose of life and behavior support plans? The purpose of life plans and BSPs is to get a better understanding of the residents through their wants, needs, and history. We get to track how they are progressing through the years with these plans. Life plans are broken up into several categories like introducing me, home, let me tell you about my day, my health and my medications, relationships, my happiness, and my school. These categories give insight into different aspects of their lives. We learn about their relationships with their families growing up and in the present. It details likes, dislikes, behaviors and drills, verbal prompts for task, independence level, social needs screening, and incentive plans if in place. Any service a resident receives will also be noted in a life plan. This program works with adults with developmental disabilities, so it is very important to learn their history to determine the best way to support them. Their levels of supervision, behavioral, and medical emergency room plans are explained. So, are the plans a good reflection of the individuals living in the IRAs? Well, based on my interactions with the residents, I have concluded that the BSPs and life plans accurately reflect the residents' personalities, feelings, and behaviors. Some behaviors I've witnessed that were also stated in the plan were excessively calling parents, agitation with authority figures, poor hygiene practices, learned helplessness, and dishonesty. In IRA number 1, I've made note of the ways the individuals interacted with each other, how they communicated with their DSPs, and the stories they shared with me. Some individuals would also direct their peers in a parental manner. For example, one of the women in IRA number 1 dropped a house phone and caused the battery to fall out. One of her housemates yelled at her and took the phone to put it back together. She assumed the resident who dropped the phone wasn't capable of fixing it herself. Behavior plans for each individual prepares you to expect interactions like this. So how does staff turnover and deployment relate to importance of these plans? I would say that since there's an issue with staff deployment and high turnover, we can expect many DSPs who are not very familiar with residence plans and house rules to work in their homes. So the plans are useful to prepare new employees on what to expect. I noticed that staff who are very familiar with the house rules and have been in the field for years are able to anticipate behaviors and work to prevent it. For instance, one individual had a bathroom accident, and the DSPs discussed not letting a specific housemate know about it because she will claim to also be sick for attention. Being able to anticipate these types of behaviors will come with the experience of working in each specific house and getting to know the individuals. BSPs are a great starting point to get to know the people you will work with. So, how does Skip R training relate to life plans and BSPs? Well, behavior plans incorporate Skip R training. Some behavior plans have explicitly stated to redirect an individual when they act in inappropriate ways. These are methods that are taught in Skip R training class that are effective with most residents. One of the challenges of working with adults with developmental disabilities is finding a balance between independence and maintaining order. Skip our ideologies emphasize the importance of supporting the disabled community to live fulfilling lives. Staff are instructed to not overstep certain boundaries while providing care. Residents are free to express themselves by making their own decisions. Staff are also not allowed to punish them. One example is if an individual displayed challenging behavior on an outing, staff is prohibited from withholding future outings. In IRA number 1, one of the DSPs requested to leave one of the residents behind on the next trip to the grocery store due to unsafe behaviors in the car ride. Her request was denied because it is a form of punishment. There are some individuals with rights restrictions and incentive plans due to challenging behavior becoming a health risk. IRA number 4 has an individual with an extensive history of elopements. This led to a process to restrict his rights for safety purposes. The program's manager had to sign off on a request to restrict the individual's rights. They suggested flashing light alarms and a video camera outside his room to catch any potential injuries in his escape. They had to show documentation on the elopements and severe injury he received to obtain a rights restriction. They also had to prove less restrictive efforts were ineffective. There is a fade out criteria that is in place with restrictions, meaning they are not intended to be permanent. The Human Rights Committee, Informed Consent Committee, and Behavior Review Committee must review the request. One of the individuals in IRA number 1 has an incentive plan to do her complete house chores in order to use her electronics. They also had to prove that she was refusing to complete any hygienic task for weeks and it was becoming a health issue. The existence of a rights restriction and incentive plan initially seemed like a form of punishment, which directly contradicts Skip R training. It would otherwise be considered punishment or unethical if the DSPs decided to take the electronics on their own without approval. Skip R is the first level of behavior prevention and intervention. We have other levels for when the teachings of Skip R aren't enough to support this community to the best of our abilities. When evaluating Skip R from this perspective, it becomes more clear that it is successful in achieving what it is designed to do. This technique for crisis management is in response to previous rights violations and abuses of special needs individuals in modern history. Skip R restricts DSP from using violence for punishment or methods to achieve compliance. With the inclusion of an incentive plan, this individual regularly takes showers, does her laundry, and uses seat covers and menstrual products during menstruation. These outcomes are evidence of an effective system in place for health and safety purposes. One of the ways I evaluated how staff handle behavioral issues and maintain structures is through coping skills. Coping skills are techniques used to manage stress and promote mental health. I was looking to see if the residents were using the skills their staff encourages and if they gave the desired result. I observed the individuals resolving issues in a way that shows that they are using coping skills and advice from staff. I remember a group conversation about music caused one of the residents to become frustrated with her housemate because the housemate kept talking over her. The resident was respectful with her request for her housemate to stop interrupting. She is prone to emotional outbursts, so this interaction shows growth and improvement. Another housemate has a tendency to ask for assistance with tasks she is capable of completing on her own. The DSPs always ask her if she tried on her own before asking for help. She is aware of her obligation to attempt the task on her own before asking, but she doesn't always follow through. There was one time when she was asking for assistance, and one of the DSPs said, "Before we ask for help, we have to do what?" And she responded, "To try to do it ourselves." This is a successful result of continuous prompting, as suggested in her behavior plan. The role of a DSP is to promote independence and help integrate residents into society. Skip training can improve staff interactions by training them on how to work with specific individuals instead of generalized training. Behaviorists can work with staff to go over BSPs and role play conflicts so the staff will know how to handle these issues in the future. Early intervention, active intervention strategies are redirection, distraction, lowering demands. Skip R training can improve by going into more detail in these three categories. The instructors often gave their own examples when they have utilized prevention, early intervention, and calming strategies. DSPs in the class also shared their own anecdotes. A role-playing exercise will be helpful for DSPs, especially first-time trainees, to learn calming language and techniques to utilize in the field. DSPs are only tested on their abilities for physical intervention, not proactive verbal or nonverbal strategies. The Vanderheiden survey revealed that all residents in residence number 1 have an overall positive experience in their IRA. Qualitatively, the residents were most satisfied with the staff and living conditions. One resident told me she chose this specific IRA as opposed to another IRA because she gets her own room and she didn't want to have any roommates. So they have an average, on average, they have the same complaint, which is not liking their housemates. Many conflicting personalities leads to altercations between residents and in some cases staff. The Vanderheiden assessment is a series of statements used to evaluate resident satisfaction with their IRA. Residents get to rank how accurately the statement reflects their own feelings about their experience with Vanderheiden. The answers reveal if residents are getting their needs met and if they are happy with the treatment they receive from their DSPs. So this assessment is used to assess SCIP-R qualitatively. Responses to statements like, I feel I get the kind of help here I really need, and learning how to help myself is the biggest help I get here, expose how the residents feel about their treatment and the support that they're getting with Vanderheiden, which includes SCIP-R principles. Yearly behavior tracking notes of incidents keep count of inappropriate or aggressive behaviors. One house member had 16 instances of effective communication and 3 deep breathing relaxation exercises in January 2025. There was an increase in the medication Abilify December 2023 for this specific residence. So tracking keeps records of positive and negative behaviors to determine if changes like medication dosage or lifestyle choices are improving their behaviors and well-being. Tracking is needed if human rights committees need evidence to restrict a right for safety purposes. Between March and April 2024, one individual went from 20 negative interactions to 5. In those months, their positive behaviors went up from 23 to 29. This slide includes all of the questions in the survey and the answer choices. The number to the right of the answer reflects how many residents responded with that particular answer. For example, statement number 1, the services I get from Vanderheiden are a big help for me. 6 residents responded all the time and 1 responded sometimes. The majority of these responses reflect positively on Vanderheiden and SCIP-R from the resident's perspective. Overall, this data indicates a safe environment for individuals to grow and learn as intended. When individuals face a crisis, they have someone to talk to. They also have activities that make them feel fulfilled. SCIP-R training stresses how important it is. Daniel's Law is a law to replace police with mobile mental health services for mental health crises. This law is named after Daniel Prude, a man who suffered from a PCP-induced mental health crisis and was subsequently restrained and killed by police officers. Officers do not always have specialized training to de-escalate these situations. This will affect residents because there will be a decrease in police interventions if we utilize mobile services. My goal is to advocate for less police involvement in support of the ideas stated in Daniel's Law. Police interventions can be very stressful for residents. There was a conversation between a resident and management in IRA number 2 regarding boundary crossing. The resident was interfering with the peer's cell phone charger. The conversation briefly became unpleasant when the police were mentioned. Management reminded the resident that tampering with another person's belongings could result in police intervention. The resident was very upset due to his criminal record. He has a history of damaging his housemates' belongings. After speaking with my supervisor and IRA number two's residential manager during a treatment team meeting, it became more clear when mobile crisis services are used and when the police are called. When an individual is threatening self-harm or is in emotional distress, DSPs are encouraged to utilize mobile crisis services such as NY Start. When altercations become physically dangerous or cross into illegal territory, police must be called. This is a requirement stated in behavior plans. This slide is the SWOT analysis for Daniel's Law. Most of these points have already been addressed. The New York Civil Liberties Union, or NYCLU, is a civil rights organization that supports Daniel's Law. They believe the weakness is managing issues that becomes more threatening. One of the threats for this law is getting the funds for this program. The promotional photo for Skip R revision. I explained the benefits of focusing on the individual when training. We will improve communication, consistency, and care and improve prevention and de-escalation techniques. This photo is intended to persuade management in the program to adopt new practices for training. Altering the Skip R program is much more complex and it will involve the OPWDD and a lot of research. This could be one of the first steps to seeing change. Skip R wasn't designed to stop behaviors. It was designed to be the least restrictive method to protect the individuals. The benefit of using Skip R is it's designed to support individuals to live their lives on their own terms. It was created to guide residents without controlling them. Autonomy is a major value in this program. However, autonomy comes with risk. Many of the individuals have made decisions that have put themselves in harm's way. DSPs and resident relationships often mimic that of parent and child. However, there are certain instances that remind you DSPs don't have control over residents' decisions in the way a parent would for their minor child. Some residents have been involved in abusive relationships and make poor health decisions. DSPs are limited in how much they can intervene. Treatment teams typically occur every 2 weeks with resident managers, resident supervisors, DSPs, a nurse, a behaviorist, and program managers in attendance. These meetings are not mandatory for all members to attend, and there's also an option to attend via Zoom. The treatment team reviews physical interventions, incidences, injuries, medical concerns, safety plans, level of supervision, boundary concerns, and home visits. Any questions, comments, or concerns that arise between meetings will be addressed. The topics discussed in these meetings set the tone for what will occur for the next few weeks. They review past events and make decisions to improve the outcomes. In a previous treatment team meeting, IRA number 1 addressed an uptick in behaviors following home visits for one of their residents. Staff confirmed the individual's parents will take her on weekends for several weeks in a row and then take long breaks from their visits. This resident is the same individual who has restrictions on phone calls to her mom because it can become excessive. The treatment team looks into issues like this and determines the best way to navigate it moving forward. There is an extensive process for residents being placed in IRAs. Vander Heiden has to notify the state of any vacancies they have. Then they will receive applicants to see who is fit. They can deny an applicant if they aren't able to support their needs. The resident gets an overnight visit and has dinner with the IRA before officially moving in. The houses have something called a House Plan for Protective Oversight, HPPO. IRA number 3 is a residence for 8 individuals 18 years and older. HPPO set up a purpose for the IRA, which in this case is to promote growth and development into adulthood so residents can live independent lifestyles. The behaviors in IRA number 3 are elopement, aggression, and self-harm. It is important to consider this detail when placing a new resident in the house. Clashing personalities and behavior should be considered when placing a resident in a house. For example, individuals that make a lot of noise should not be placed with residents that are sensitive to noisy environments. Residents appear to be placed based on independence level and in some cases gender. Other restrictions would likely make this process even more challenging. SKIP is an amalgamation of other crisis prevention techniques. It is a basic level of handling issues before higher authorities get involved. There is no guarantee for a positive outcome using SKIP. However, based on observations and assessments, I would say SKIP is successful in maintaining a functioning IRA. Any changes to SKIP R training will have to be achieved through the OPWDD. The suggestions I provided were well received, but more has to be done for the ideas to be implemented. I had some concerns surrounding my limitations on information I had access to as an intern. Only behaviorists have access to recent tracking data, so I had to rely on some archive data, behavior plans, life plans, communication logs, treatment team notes, and Van der Heyden assessments to conduct my evaluation. Considering SKIP-R is just the first defense of behavioral support, it is successful in managing behavioral concerns in this particular program. My experience in another organization for adults with developmental disabilities shows how improper use of SKIP-R could render these techniques ineffective. If SKIP-R is the only defense that is used, and there is a lack of documentation on extreme behavior, we can expect limited behavioral improvements. A major takeaway from the process of evaluating SKIP-R is these strategies aren't intended to be a solution to behavioral challenges. SKIP-R was just created to protect the rights of the IDD community and prevent abuse. My experience as a DSP in a day program has distorted my understanding of some aspects of SKIP and IDD care that has been clarified in my experience interning with Van der Heyden. For example, I learned about the process to restrict rights of individuals to protect them from harmful behaviors. I wasn't aware of this layer of protection for when other methods fail. My activities, work products, and experience improved my skills working in a practical environment because it helps me improve my ability to work on self-directed projects. This was different from other work experiences because of the level of input I had in my end results. And it improved my ability to work in similar circumstances for future evaluation reports. My professional knowledge, skills, and abilities were enhanced through meetings with my Ape advisor, Sarah Dallas. Participating in a treatment team educated me on how to conduct a meeting and address topics in a respectful, productive manner. I'm grateful for this opportunity to visit a few IRAs in the program and work with residents and staff. So that concludes my presentation on my evaluation report, Effectiveness of SKIP on Behavioral Support for Adults with Intellectual and Developmental Disabilities. I would like to thank Van der Heyden for allowing me to intern with them this summer and Eastern Washington University faculty for guiding me through this experience and listening to my presentation.